Choice is essential for our freedom and autonomy. We cherish choice in our daily existence and it influences virtually every aspect of our life. Barry Schwartz, in his book, The Paradox of Choice, argues that a multitude of choices can cause confusion, anxiety, regret, dissatisfaction, and even decision paralysis. Unfortunately, the paradox of choice is not limited just to mundane and trivial matters, but extends to critical life decisions such as those which affect our health and well-being. I have been a practicing cardiac surgeon for the last 36 years, and I have witnessed firsthand the profound impact that choice can have on our health. Let me start with a small story, a story which unfortunately repeats itself multiple times each day in hospitals across our city. John is a 50-year-old man. He is in the prime of his life. He is a diabetic for a few years, but he suddenly experiences excruciating chest pain and a feeling of impending doom. He is rushed to the hospital, and an angiogram done shows multiple blockages in his coronary arteries. The cardiologist gives him two options: angioplasty or stenting, or bypass surgery. He tells him that bypass surgery may offer him a more definitive solution, but it is more invasive, will have a longer recovery time, and carries a higher immediate risk, while angioplasty or stenting is less invasive and therefore has a shorter recovery time. But he also cautions him that it might not be as durable. It may require repeat procedures and even bypass surgery in the future. John, like all of us, cherishes his freedom to choose. But faced with this critical decision, he and his family are really overwhelmed. The very act of choosing becomes a burden. Patients faced with such critical choices often feel more confused than empowered. Now we choose what we eat, where we live, what career path to follow, but can we really choose in making critical medical decisions where a bad choice can have irreversible consequences? Let us examine what are the various methods of decision making and consent. Now the traditional method is the paternalistic model, where the only guiding principle for the physician was primum non nocere, as said in Latin. This is from the time of Hippocrates, 2500 years. The physician knows it all. He takes a treatment decision and he implements it. Now this was okay till about 100 years ago, when there were limited choices, and more importantly, public faith in physicians was very high. In the 21st century, public faith in physicians is at a low of about 25 to 30%. We also now appreciate that disease is a physiological term, acute coronary syndrome or a heart attack, while illness is perceived at a personal level, at an individual level, and therefore a patient's values, his preferences and his needs need to be taken into account. Therefore, there is a conflict between the paternalistic model and the autonomy model of self-determination. In 1914, there was a landmark New York judgment. A judge ruled that every human being of sound mind and adult years has a right to determine what shall be done with his own body. This marked the start of the issue of patient autonomy, and it became the indispensable principle for the ethical practice of medicine. So there was a gradual shift away from paternalism towards patient autonomy based on social forces, legislation, and finally, today, informed consent is the only legally accepted method of decision making as well as consent. So what is the centrality of this principle? It prohibits, under ordinary circumstances, the imposition of any medical treatment on a competent adult patient without his or her free will and informed consent. So we need to delve into this a little bit in detail. There is a one-way, emphasis on one-way transfer of information from the doctor to the patient. The patient is then expected to deliberate on this information and reach a decision which is authentically his own, legally. However, in non-Western civilizations, especially in countries like India, the patient often, because of economic and social reasons, has a very compliant, passive role. It is family members, or in fact, sometimes the dominant male members who take all the decisions. So while legally the patient is at liberty to take a decision, he is not really equipped to do so. And therefore, this strips him of his autonomy. The second important feature is that there is no mandate as to how much information needs to be passed on from the doctor to the patient. What might be relevant to the doctor may not be relevant to the patient, or vice versa. The asymmetry of medical knowledge between a doctor and a patient cannot be bridged by a mere conversation. So this particular fact needs to be borne in mind. Besides, doctors also suffer from biases like do all of us. Now, there was a very famous study because research has actually shown that doctors who infer rather than explicitly elicit patient information, patient preferences often get it wrong. There is a famous study which involved thousands of patients with breast cancer. And what did doctors infer? That maybe they thought that 75% of the women would prefer breast conservation therapies. But when the patient's preferences were elicited, just 7% gave breast conservation prime importance, a tenfold difference. It is also very important that the patient feels very secure and safe in the hospital environment when he gives consent or takes a decision. He should not fear disrupting the doctor-patient relationship or the quality of care. Similarly, the method of taking consent by the doctor himself. It can be quite coercive, which is totally unacceptable. It can be manipulative, wherein the doctor presents the information in a very deceptive manner so that the patient is influenced to take a decision which is compliant with the doctor's view. This is a real threat in today's world of commercialized medicine. The only ethical way is persuasion. Persuasion on the merit of reason. Now, faced with all these complexities, patients somehow tend to give up their personal autonomy and hand it back to the paternalistic model, leaving their faith in the expertise of the doctor and believing more in eminence-based rather than evidence-based medicine, which is rather unfortunate. There is a third model. The third model is one which refers to optional autonomy or a shared decision-making model. Unfortunately, this has found favor with both doctors and patients, but unfortunately it is limited to non-urgent situations. Most critical decisions in medicine need to be made in a very time-bound manner, and the luxury of time does not exist. So, in making all these choices, we must understand that judgment and choice is not the same thing. Choice comes with consequences, and consequences are always uncertain. Besides, choice and their consequences are always separated by time. We get the benefits now, but we pay the cost later. So for every different treatment option, there can be a range of different outcomes, which can affect us positively or negatively. They can affect our physical, our mental, or our functional status. So truly making a choice for complex medical decisions is a truly formidable task. So how do humans make decisions? Daniel Kahneman, Nobel laureate 2002, unfortunately passed away a few months ago, was considered to be the world's leading authority on judgment and decision making. And he made a statement which I'm sure will surprise most of you here, when he said, humans are incorrigibly inconsistent in making summary judgments of complex information. It's not such a complicated sentence if you think about it. And he also added that we are highly influenced by how our choices are framed. So in case of John, our patient, he was told that surgery is an invasive option with a longer recovery and a higher risk. Angioplasty has a shorter recovery and a lower risk and is less invasive. So how the choices are framed influences the patient's choice a great deal. Now, this is considered to be one of the most important graphs in the social sciences, and it is in the realm of organ donation. Now, these are all countries, European countries, with similar social economic backgrounds. And in countries where the default option is presumed consent, when you apply for a driving license, it is assumed that you are giving consent for organ donation. The rates of organ donation are extremely high. But in countries where explicit consent is needed, the rates of donation remain extremely or dismally low, as it is so in a country like India. Now, this is a very important book. It's called The Little Book. It was published 70 years ago by Paul Neal, who was president of the American Psychological Association. It's the book called Clinical versus Statistical Prediction. He also made a very categorical statement that in a contest between humans and algorithms, the result is in favor of predictive statistics, especially in domains that entail uncertainty and unpredictability. Now, in medicine, this is found to be true. Algorithms predict longevity of cancer patients, length of hospital stay, far more accurately than human expertise. This is a very famous Ashenfelter phenomenon. Professor Ashenfelter from Princeton University devised a formula where he could predict the future price of fine Bordeaux wine based on current climatic conditions far more accurately, with a 90% accuracy, which was more than what human experts could. Coming back to medicine, I think this lady, Dr. Virginia Apgar, should have been given the Nobel Prize. She devised a very simple score. It is called the Apgar score. It assesses the health of a newborn baby and looks for signs of distress by evaluating 5 factors in less than 30 seconds. A score of above 10 tells us that the baby is absolutely healthy. A score below 4 suggests that the baby needs urgent medical evaluation. This simple, reproducible score, in spite of all technological advances, is being used for the last 70 years across the globe and has saved countless millions of lives. Is there any such score available for our patient John? You remember him? He had a heart attack, he had an angiogram. Fortunately, there is, and it's called the syntax score. It's a simple anatomical score. It adds up the number of blockages to give you a score. So the higher the number of blockages, the higher is the syntax score. And various scientific studies, randomized controlled trials, which stand at the pinnacle of the pyramid of evidence, have shown that the probability of survival is far better with bypass surgery as compared to stenting in patients with a high syntax score or patients with higher number of blockages. Similarly, I mentioned that John was diabetic. There is a famous freedom trial which involved thousands of patients with diabetes randomized to stenting or bypass surgery. What did the results show? That the probability of survival for bypass surgery patients at 5 and 10 years after the procedure are far higher for bypass surgery patients. Is this information shared with John? Unfortunately, these scores are neither calculated, neither is this relevant information shared with the patient, not only in India, but across the globe, because there is no mandatory requirement. Now, this is a study published in Nature. We all know it is one of the premier scientific journals in the world. This article published in 2022 from publications taken from around the world show that bypass surgery definitely has better results than stenting in most subsets of patients. But what are the trends? The slide to your left is from the UK and the one on the right is from the US. The number of stenting procedures is increasing exponentially while the number of bypass surgery procedures are static over the last decade. Why is this so? In spite of the better results. The reasons are lack of relevant information being provided to the patient, framing of the choices given to the patient, and of course, human behavior. Taking a medical decision at a critical time puts the brain under a lot of stress. Our brain has actually evolved over the millennia and it releases a hormone called cortisol, which actually inhibits rational thinking. One of the pervasive features of human behavior is that we are very, very optimistic. It is a natural instinct to take decisions based on our intuition rather than on a rational basis. We abhor risk. We dislike risk. We are extremely loss averse and therefore we take decisions which might be of less than expected value. To overcome our natural instincts, it needs a deliberate act, an act of commission, an act of effortful deliberation. Unfortunately, when time-bound critical decisions need to be made, there is no time for effortful deliberation and therefore we take decisions based on our intuition. Now, to overcome this problem, Richard Thaler, another Nobel laureate in economics, and Carl Sunstein, a professor of humanities and law at Harvard Law School, have written a book. It's called Nudge. We all know what nudge means. Invariably, we want to say, we look at it in a positive sense, nudge in the right direction. So they say a nudge is meant to help people make good decisions without curtailing their freedom. So they have used this term libertarian paternalism. Libertarian means preserving choice And paternalism basically means an effort to help patients make errors in their choices by providing them with all information available. So nudges are designed to help people make decisions for their long-term interest. Now this is applicable in business, it is applicable for medicine. So ladies and gentlemen, are we really expecting that our patients should be their own physicians? Are we expecting patients to take decisions based on hearsay and anecdotal experiences? Are we only providing them with limited information so that we believe in the old adage that ignorance is bliss? You know, it is really surprising that patient choice is a class 1 indication. That means it overrides all other indications for any procedure. Indications are all based on evidence, but patient choice is based on patient autonomy and is not based on evidence. So I believe that we can improve this whole process of decision making and consent by making it necessary to have mandatory disclosure of relevant information. We have mandatory disclosure in so many domains of our life, of our daily life. Unfortunately, a lot of it is always in fine print and we don't pay much attention. But it is available for our finances, for our taxes, for so many things. Isn't life, our own health, the most precious commodity that we have? It is our right to know all the relevant information to enable us and our families to make a rational choice. We take medical insurance, we take life insurance, we take motor car insurance, we plan for our retirement. All of this is for future uncertainties in our life. While we should of course hope for the best, but we must plan for the worst. And therefore all of us must realize that we might fall to some illness in the future. And therefore we must know to what questions to ask, to what answers we want to get, so that we can take good decisions. As the famous Greek poet Archilochus said more than 2000 years ago, that we do not rise to our challenges, we fall to the level of our preparedness. Thank you.